Hypocalcemia in the setting of high PTH, our discussion will start on the genetic causes, and then we can go through certainly acquired causes to follow. The inherited causes, as you can expect, tells us a fair amount about physiology. Let's talk about pseudo-hypoparathyroidism first. There's a fair amount of complexity around the genetics of pseudo-hypoparathyroidism. You may recall from your genetics knowledge in the past or currently that there's a phenomenon where you can have so-called imprinting, where the phenotype is different depending on whether the inherited abnormality comes from mom or dad. This is one of those syndromes in which that can occur. Okay, so clinical presentation, as the name implies, pseudo-hypoparathyroidism, then PTHs will be predictably high, pseudo implying that phenomenon. And this is a situation in which you have peripheral insensitivity to parathyroid hormone. So I would have the expected phenotype of low serum calcium and high phosphorus. We shouldn't have to belabor those points anymore since we've gone over them so many times. And then you'll have this so-called osteodystrophy or Albright's hereditary dystrophy that may manifest in a variety of ways, developmental delay and skeletal malformations that are characteristic of that. There are also sort of characteristic features in the fingers. Classically, your ring finger length can be shorter than the other fingers. So those are phenomenon of this so-called Albright's hereditary osteodystrophy. Again, pathophysiology is divided into a couple of different subtypes, but in general, this is again is a insensitivity to parathyroid hormone. Now, this is an abnormality in a signal transduction of PTH at its receptor through G proteins. You'll recall G proteins are a canonical mechanism of signal transduction whereby multiple hormones can exert their effects, and so that makes sense when we go through the phenotype here. We're going forward on a discussion around maternal inheritance. The paternal inheritance will come later. Again, that phenomenon is called genetic imprinting. I have a problem with this G protein. The gene is GNAS1. Such that PTH is not able to exert its biologic effect. Patients may also have, because this G protein mechanism of signal transduction is also important for thyroid hormone to exert its effect, as well as gonadotropins, glucagon, calcitonin, and gonadotropin releasing hormone. These let's call it deficiencies. The hormones are elevated, but their biologic effect is deficient, will result in predictable phenotype, right? Hypothyroidism, for instance, will be amongst the phenotypic manifestations of this disease. Okay. With paternal inheritance, there is a predominance of the skeletal malformations, that is the Albright's hereditary osteodystrophy. There is not the effect on hormonal responses or responses to hormones. It's primarily the dystrophic manifestations in the skeleton that are manifest in that scenario. Okay, and probably we don't need to belabor the other sort of variants of this pseudo hypoparathyroidism. I think again, the important point is to use these overview understandings of genetic diseases to understand the underlying biology of parathyroid hormone and its effect. So we'll gloss over some of those subtypes since this is obviously a very rare disease and move on in the interest of time to other forms of, again, hypocalcemia with high PTH. We're in the genetic causes, right? So Let's talk about these forms of vitamin D abnormalities, okay? Vitamin D resistant rickets, as the name implies, even if you give vitamin D, the problem is not fixed. And then there's vitamin D dependent rickets, where vitamin D can solve the problem. Okay, so these are autosomal recessive disorders. They present with hypocalcemia and rickets. Early onset manifestations are characteristic in their features amongst children. Again, let's talk about the biology. In vitamin D resistant rickets, there may be a problem in the vitamin D receptor, resulting in, again, a resistance to vitamin D and correcting the abnormality. So predictably, they will have hypocalcemia and PTH will be elevated. In vitamin D dependent rickets, there's a mutation in the enzyme that converts 25-hydroxy vitamin D into 1,25-hydroxy vitamin D. That is, 1-alpha hydroxylase enzyme is deficient in so-called vitamin D dependent rickets. Okay, and so obviously then these patients will have deficiencies in calcitriol. Giving them calcitriol will result in improvements in this cause of hypocalcemia. There's another form of vitamin D dependent rickets in which I have a mutation in the 25 hydroxy vitamin D, sorry, the 25 hydroxylase enzyme. So, we hopefully don't need to belabor those points, but I'll just give you a quick glimpse of the biologic pathways of calcitriol production. You, of course, recall that you can take these vitamin D precursors, you can 25 hydroxylate them, and then 1-alpha hydroxylation results in the most potent form of vitamin D, that is calcitriol. Okay, so again, I can have deficiencies in either of these enzymes that are creating these end products of vitamin D metabolism. Okay, so let's continue then on to the more common acquired forms of hypocalcemia with high PTH. So alkalemia or correction of severe acidemia can result in hypocalcemia. So when I'm correcting these underlying physiologic states or pathophysiologic states, I essentially create more opportunities for free calcium or for calcium to bind to ionized or anions in various compartments, right? So one major anion is going to be albumin, right? When I have alkalemia, I have less proton binding to the negatively charged albumin molecule, right? So this is normally occupied by protons. Albumin has these overall a net negative charge. When alkalemia ensues, right, I have less proton available for binding, and so albumin starts to bind calcium. So ionized calciums can decrease in that scenario. Okay. The same would be true, though, if I have the huge buffer pool that is provided by bone, right? It's calcium hydroxyapatite. Calcium is bound to carbonate as well as phosphate. And so when I displace protons from bone, bone also has the ability to start sopping up calcium, right? So that's another place that calcium goes when you correct severe acidemia or you develop alkalemia, right? Vitamin D or calcitriol deficiencies would have obvious, again, manifestations of low serum calcium with high PTH. Generally, this is must be, we said this in the past, this needs to be long-standing in order for you to exhibit hypocalcemia. That is to say, remember, days or weeks or even months of vitamin D deficiency, right, which you see commonly in clinic, is not associated with hypocalcemia, right? You see plenty of people with undetectable vitamin D levels, but having normal serum calciums, right? And the reason that they can protect themselves from manifesting calcium is that, unlike other solutes, which we talked about, where just a few days of deficiency can manifest as X, right? Hypokalemia, for instance. You have this large pool of available calcium that can be mobilized by parathyroid hormone in order to defend from a reduction in ECF concentrations, right? So patients that manifest hypocalcemia are typically going to have osteomalacia in their bone, right? It's either that or they have some form of adynamic bone, right? Perhaps they have, for instance, fluoride toxicity, right? Something esoteric, but RFK Jr. would make sure he points out, right? Or aluminum toxicity, right? That would be a situation in which you have a bone that is adynamic, meaning it's less responsive to your let's call them osteoclast and osteoblast regulating hormones, right? And so that patient can manifest hypocalcemia even with modest durations of vitamin D deficiency. Okay. I don't think we need to talk much about pathophysiology because we've gone through, the biologic pathway of vitamin D just recently. I guess there is several risk factors that can be associated with vitamin D deficiency, including breastfeeding infants, right, who are not getting the benefits of vitamin D supplementation that is pretty routine and formula as well as cow milk, right? Elderly people with dark skin; those are patients that would be at risk for vitamin D deficiency. Vitamin D is a fat soluble hormone, and so fat malabsorption would also be a risk factor for vitamin D deficiency. You can have liver disease, which may impair this conversion of vitamin D into that intermediate active form, 25-hydroxy vitamin D. So theoretically, profound liver disease, not just through malnutrition, but through impaired biosynthesis, can be associated with vitamin D deficiency. And of course, you're very familiar how chronic kidney disease is associated with vitamin D deficiency. We've gone over, for instance, the effect of FGF23, right? Phosphate retention increases FGF23 levels, and FGF23 is a potent negative regulator of 1-alpha hydroxylase, right? Okay, so there's another interesting angle that you should be aware of. This is not rare. Patients who are on P450 enzyme inducers, such as carbamazepine and phenytoin, would be at risk for vitamin D deficiency as well. So remember, these cholesterol hormones are utilizing your P450 enzyme system for metabolism. And so if you are increasing the turnover of these cholesterol hormones, you can cause a state of deficiency. Okay. So that is pretty well described. Long-term use of carbamazepine or phenytoin, that is dilantin, can be associated with vitamin D deficiencies in pediatric patients and also in adults. Right. Obviously, we're going to check vitamin D levels or calcitriol levels. Notice that there will be a compensatory rise in PTH. Okay. Moving on to other acquired forms of hypocalcemia include medications. One that you'll see very commonly because you create this problem is citrate. So citrate toxicity can be associated with low ionized calciums. So the classic picture is a calcium that is normal, that is ionized calcium that is normal or low, and a total calcium which looks high or normal. I suppose you can even play out both of those possibilities, right? So again, we have citrate that is bound to the calcium. The calcium citrate in circulation is measured amongst your total calcium measurement, right? So calcium phosphate, calcium bound to albumin, those are captured by the total calcium measurement, including calcium citrate. So you can have a total calcium which is normal or high, even though my ionized calcium in that scenario would tend to be low, right? So that's clearly something you are familiar with in your experience with citrate anticoagulation with CRRT. Liver disease is a risk factor for this. I made the point in our discussion around renal replacement therapy. Other risk factors are obviously excess citrate infusion rates. So by and large, remember, when you switch someone to citrate, you should be simultaneously trying to get them on the lowest possible blood flow, right? Because my citrate infusion rate is a function of my blood flow rate, right? And so you remember the rules of thumb for minimum blood flow rates for CRT prescriptions, whether they're on pre-filter fluids or dialysate fluids. Remember that's 6 times your pre-filter fluid rate or 2.5 times my dialysate fluid rate, right? So look to those ratios, march your blood flow down routinely. You should do this, not after they get citrate toxicity. You should march your blood flow as low as you can get away with without nurses calling you, okay, which is usually 100 blood flow. Right? You can theoretically go lower than that in many cases, but then you'll start getting nursing calls because they'll get cannot detect access alarms, right? Okay. So again, usually it's 100 blood flow rate, and then you set your citrate infusion at 150 or 180 as a starting point. Those are typical sort of parameters that I use, right? There's one other risk factor for citrate toxicity, right? Liver disease, excess infusion rates, but low dose citrate. I generally do not lower the dose below 2 liters an hour when I have citrate on board because dialysis and hemofiltration are clearing citrate. They're your friend. So when you lower the dose of CRT, you're reducing the clearance of citrate and increasing the risk of citrate toxicity. That's pretty high yield. Any questions about that? I'm going to pause for a breath. Okay, then let's keep rolling. Bisphosphonates, okay, they inhibit bone resorption, as does denosumab. This is a common cause of hypocalcemia in the onconephrology realm. So you'll see that low calcium. It may not be top of mind because you're dealing with you're frying other fish. But if you'll look, you'll see many of these patients, myeloma patients, breast cancer patients, those are people who very commonly, as routine care, are getting anti-resorptive therapies. And what you will see is a low calcium and then PTH, which is response elevated. Okay, so look for that. You'll have to look through the old outpatient chart because that effect would have been is the result of some intervention that happened 2 months ago. Okay, foscarnet. Uh-oh, locked up here. Okay. I'll wait for this to restart, but I'll uh, still try and keep the topics in mind. Foscarnet is a drug that can bind. It is negatively charged and binds the cation calcium, and so it can be associated with low ionized calcium as well. It tends to be associated with magnesium depletion through tubulotoxicity. So that would be another mechanism whereby foscarnet can cause a hypocalcemia. We'll talk about foscarnet when we talk about hypomagnesemia. So that would be another mechanism. But again, it can bind free calcium and therefore um, result in a low ionized calcium. Okay, acute pancreatitis is another scenario in which you can think of binding calcium. In this case, uh, potentially in the inflamed pancreas, which has negatively charged fatty acids that might be exposed by this inflammatory response, and that can bind calcium, reducing free calcium levels. Of course, we've talked about another mechanism where you've commonly seen low calcium, and that is any systemic inflammatory response may be associated with increases in calcitonin. That's a negative regulator of PTH's effect on the bone, right? We talked about calcitonin being one of your biomarkers that you sometimes use to evaluate, for instance, community-acquired pneumonia. There may be a peripheral insensitivity to PTH. So that would be another mechanism where pancreatitis would be associated with hypocalcemia. Osteoblastic metastases, there are certain tumors, particularly breast and prostate cancer, that can be associated with a production of, let's call it osteoblast activating or stimulating factors that would result in robust osteoblast activity and inhibition of osteoclast function. The result could be a low calcium in that scenario. Remember, the more common is these patients received a dose of bisphosphonate and they now are hypocalcemic because of that, not because of the osteoblastic malignancy. That would be much less common, but is certainly a possibility. Okay. Moving to the end here of hypocalcemia, we can talk about all those syndromes that are associated with an increase in ECF phosphate. So phosphate can bind calcium and can reduce even total calcium. That should sort of kind of be a bit of a head scratcher, right? Total calcium supposedly captures calcium that is bound to things, not just free calcium. It turns out that there's probably an interaction or a interaction of very high phosphate with the bioassay for total calcium. So that's most likely much of the reason why total calcium can be high in severe hyperphosphatemia, because otherwise it doesn't quite make sense, does it? Because it would be measuring that bound calcium. So really high phosphate can presumably interfere with the assay for total calcium. Okay, so these are all the syndromes which we've talked about. Well, I guess I'll just briefly say it. These are syndromes that can be associated with a release of intracellular phosphate into the extracellular fluid compartment, right? Other features that are typical for instance, tumor lysis, in particular rhabdomyolysis, are going to be hyperkalemia. We look for hyperuricemia in these scenarios, in addition to the ECA or the hyperphosphatemia, okay? Acute kidney injury might be the result of these conditions, and the mechanism is uric acid or calcium phosphate nephrotoxicity or crystalline nephropathy. I see this sort of mental shortcut that happens a lot where patients are, or acute kidney injury in a cancer patient is attributed to tumor lysis, even though the uric acid is 10 and the phosphate is 6, right? They say, oh, tumor lysis classically has high LDH, has the underlying lymphoma, recently received chemotherapy, hyperuricemia and hyperphosphatemia. Those are all your check boxes for tumor lysis, but nobody develops crystalline nephropathy from a uric acid of 10, right? That's what you see in your primary care clinics, right? You see a uric acid of 10, right? Or a phosphate of 6. Nobody in CKD clinic is developing acute kidney injury from a phosphate of 6. So in order to attribute the acute kidney injury from those mechanisms from tumor lysis, you'll have to see more significant elevations in those two solutes, right? Typically, I'm expecting to see uric acids in the 13 plus range before I start getting sort of convinced that this is a mechanism of injury in the patient. There's often a chicken or egg question, right? Renal insufficiency with high cell turnover will be associated with hyperuricemia, right? And so it is often a secondary elevation to 10 or something in a patient who has acute kidney injury in that context, okay? We generally espouse conservative calcium supplementation in the patient with rhabdomyolysis, because there can be a rebound hypercalcemia that can be quite marked in that context, as calcium, which is bound to intracellular molecules within damaged muscle, can be liberated and result in a rebound hypercalcemia. So we generally espouse being conservative with calcium supplementation in rhabdo-induced hypocalcemia. Any questions?